Welcome to the Multiple Sclerosis Summit Series Part 1, presented by the Northwestern University Feinberg School of Medicine at NeuroSeries Live. My name is Dr. Bruce Cohen from the Davey Department of Neurology, Northwestern University Feinberg School of Medicine, and the Northwestern Comprehensive Multiple Sclerosis Program. You're tuned in to a live session called The Changing Landscape of Multiple Sclerosis, New and Emerging Disease-Modifying Therapies. I'm pleased to serve as the chair of the first Multiple Sclerosis Virtual Education Summit Series. Over the course of this three-part series, we will be talking about disease-modifying therapies and how to choose among them for a particular patient, differential diagnosis of multiple sclerosis, maximizing adherence to disease-modifying therapies, and strategies for treating symptoms and optimizing function in patients with MS. Today, you're tuned to the initial presentation in this series, a live session entitled The Changing Landscape of Multiple Sclerosis, New and Emerging Disease-Modifying Therapies. I will present some recent clinical data on newer approved disease-modifying therapies and briefly touch on some emerging therapies currently in Phase 3 clinical trials. In the segment which follows, Dr. Fred Lublin from the Corinne Goldsmith Dickinson MS Center at the Icahn School of Medicine at Mount Sinai in New York will discuss considerations in choosing among these therapies for individual patients in a program entitled Disease-Modifying MS Therapies in Clinical Practice, Which Therapies for Which Patients? Before we get started, I'd like to remind our audience that you can send questions in real time during this presentation, and I'll address them following the talk. Dr. Lublin will do the same following his presentation. You can send your questions anytime during the program through the box in the lower left-hand side of your screen. Joining me today as moderator is Dr. Matthew McCoyd, Assistant Professor of Neurology and Director of the Neurology Residency Program at the Loyola University Stritch School of Medicine. Now let's get started as we go into the first talk, New and Emerging Disease-Modifying Therapies for Multiple Sclerosis. Multiple sclerosis is an inflammatory and degenerative disease of the central nervous system. Clinical features include acute symptomatic episodes termed relapses or exacerbations, and gradual accumulation of neurologic deficits with potential disability. It's the most common chronic disease affecting the central nervous system in young adults. The National Multiple Sclerosis Society estimates that there are about 400,000 cases in the US, and the risk of developing MS is about 1 in 1,000 among the general population. The highest incidence, however, occurs in Caucasians of European descent. The disease occurs about threefold more commonly in women compared to men, and most commonly presents between the ages of 20 and 50 years. The pathology of multiple sclerosis is characterized by inflammatory plaques composed of T lymphocytes, macrophages, and immunoglobulins. Chronic plaques contain reduced axons and increased macrophages, particularly in chronic active lesions. Secondary progressive multiple sclerosis is associated with lymphoid follicle-like deposits on the meninges, containing proliferating B lymphocytes, dendritic cells, and T lymphocytes. The goals of disease-modifying therapies are to prevent relapses, to suppress the evolution of lesions, and most importantly, to delay and prevent the accumulation of neurologic disability. In doing so, we want to limit treatment-related morbidity and to optimize the quality of life of those patients who are under treatment. There are now 9 different agents that have been approved by the FDA for treatment of disease in MS. The initial generation of treatments were the interferons and glatiramer acetate, which are administered by self-injection. Mitoxantrone was approved in 2000 for worsening, relapsing multiple sclerosis, secondary progressive multiple sclerosis, and progressive relapsing multiple sclerosis. However, due to its potential toxicities, it's seldom used today. More recent therapies the so-called second-generation therapies have included natalizumab and the more recently approved oral therapies. It's these therapies that we'll be talking about today. Natalizumab was the first approved monoclonal antibody for treating MS. It's a selective antibody which is directed at alpha-4 beta-1 integrin, which is expressed on activated lymphocytes. This antibody blocks the attachment of these lymphocytes to vascular cell adhesion molecule expressed on endothelial cells, and consequently migration into the central nervous system with its downstream inflammatory effects. Efficacy of natalizumab was shown in clinical trials comparing it to placebo, which demonstrated a 68% reduction in annualized relapse rate and a 42% reduction in the risk of disability progression as demonstrated by a change in the expanded disability status scale score of 1 point or more sustained for 12 weeks. In addition, there was a 59% reduction in the risk of relapse over the 2 years of the trial for those patients on natalizumab compared to those on placebo, with 77% of the natalizumab patients remaining relapse-free over that period compared to 56% of placebo. Measurements of efficacy by MRI showed an 83% reduction in the average number of new or enlarging T2 lesions, with 57% of patients on natalizumab having no new or enlarging T2 lesions compared to 15% of placebo. There was a 74% reduction in the numbers of new T1 hypointense lesions, with 63% of patients on natalizumab having no new T1 hypointense lesions compared to 27% of placebo. Although there was no reduction in cumulative brain atrophy over the 2 years of the trial, there was a smaller reduction in brain volume during the second year of the study after an increased reduction in the first year, suggesting that the early changes might reflect resolution of active inflammation at entry into the study. Natalizumab has been a safe drug with one major concern. Although a few patients develop hypersensitivity reactions, this is uncommon and occurs in less than 1% of patients. Rare cases of hepatotoxicity have been described, but the major concern with natalizumab is the increased risk of a rare brain infection known as progressive multifocal leukoencephalopathy, which is the result of a viral infection affecting the oligodendrocytes. Recently, an antibody test has become available which allows us to determine whether or not a person has the antibody, which implies that they have the virus in their body and therefore the potential to develop PML. In those individuals who have JC virus antibodies, the duration of treatment with natalizumab, and whether or not they've ever received an immune suppressive therapy in the past, such as mitoxantrone or other agents, increases the risk